people will fill in. Welcome, everyone. This is one in a series of monthly or bi-monthly seminars held by our chosen center at Columbia, which is a nascent center, the Center on the Healing of Opiate Addiction and Other Substance Disorders. And we have some different work groups, and we like to host these seminars to bring in people from all over the university and the research community together from different silos, and to think together about research. So rather than talking to ourselves within our own specific groups, we hope to attract people from really across the university and the community. So it's nice to see a good turnout. And today we're going to hear about opioid vaccines. So Sandy, I'll hand it off to you.
Okay.
You have an echo. Maybe the rest of us can mute if we're not talking. That.
All right. There we go. Thank you. Yeah, thanks everyone. I'm excited to show you some data from a NIDA grant that we got to develop this opioid vaccine. So I've been collaborating with Dr. Marco Prevatoni, who was originally at the University of Minnesota and now is at the University of Washington. So Marco will show us his data from the preclinical studies that he has run to support the clinical testing of the first vaccine that we're testing. I'll show you our clinical data, and we've invited Dr. Dana Sacco from the emergency department at Columbia to provide a perspective on the use of a biologic approach. So, we're developing both monoclonal antibodies and vaccines for the treatment of opioid use disorder and overdose. So Dana will kind of talk about, the potential utility of the monoclonal antibody approach as a medication for treating opioid overdose. And then Ned will talk about sort of the clinical implications of the vaccine for treating opioid use disorder and overdose as well. So we thought we would have a kind of nice complement of different clinical perspectives on this approach. And we're planning to have just a relatively short presentation so that we have plenty of time to discuss this type of approach. So without further ado, I'd like to introduce Dr. Marco Prevatoni. He's a professor in various departments at the University of Washington, and to give his presentation. So thank you, Marco.
All right. Well, thank you so much. I'm on the other side, of the country here. So happy. I wish to be there. So thank you, Sandy, for the nice introductions. So yes, I'm here in Seattle. I'm a professor in psychiatry, and I'm heading a department of, a center focused on medication development in the space of substance use disorders and overdose. Some of the work that I will show you here is related to inventions or co-invention that I have disclosed, related to vaccines, antibodies, and so forth. As you all know, this is a very sophisticated audience, so I don't need to go into the details, but we all know how opioid use disorders and overdose really represent an unmet public health need in the United States, and the numbers that we are seeing are staggering. And also, even more important, is this ever-changing landscape of drug use and risk that really poses a threat when patients and people out there are exposed to a variety of opioids in combination with non-opioids and other substances in various stick mixtures or counterfeit prescription pills that may contain little doses of some of these fentanyl analogs or other unknown compounds. There are obviously medications which are safe, effective, but they're not just always enough to curb the current opioid overdoses statistics. In the United States, we have only 1 out of 5 patients access treatments. So we obviously have a problem related to access, but also there are a limited number of approved pharmacotherapies for OUD and overdose. In this context, our group has been developing vaccines and monoclonal antibodies as a way to treat and prevent OUD and overdoses through active or passive vaccination. Vaccines and monoclonals provide the patient with antibodies that are selectively targeting the drug of interest, and by binding the target drug, will prevent its crossing through the blood-brain barrier, reducing or preventing or reversing some of the effects associated with opioids, including respiratory depression, bradycardia, or reward and reinforcing effects. We have demonstrated some of these effects in both small animal models as well as large animal models, and now, as Dr. Comer will show, also in human subjects. We are hoping that vaccines will and monoclonals will offer some potential benefits that they're not meant to substitute current therapies, but rather augment and provide adjuvanted strategies to current small molecule therapies. So for instance, vaccines could provide the patient with longer lasting and safe and selective and cost-effective intervention that can protect them from a potential for overdose, differently than opioid-related analogs, such as buprenorphine, methadone, and so forth. We are hoping that vaccines and monoclonals could potentially reach wider population segments. And finally, due to their selectivity, these vaccines and antibodies are designed to not interfere with current medications for pain and addiction, so that we can safely combine them with existing medications. So for instance, a vaccine could be combined with methadone, or a monoclonal antibody could be combined with naloxone or nalmefene for rescue of overdose. In this space, we have had numerous candidate vaccines. We have done quite a bit of discovery. So today, I'm just going to give you a snippet of some of the work that we've been doing. The pipeline that we have developed through the years has keep growing. And so some of these are sort of like the tip of the iceberg, and then we keep developing new vaccines. So we go from early discovery all the way to IND and phase 1 clinical trials. Our most advanced product, which Dr. Comer will talk next, is an oxycodone vaccine that targets oxycodone, hydrocodone, oxymorphone, for which we have completed the IND in 2020. And then currently we are manufacturing 2 candidate vaccines, one for heroin and its metabolites, and the other one for fentanyl and some of the analogs. And then we have other works in the pipeline, for instance, a carfentanil vaccine and other next generation formulation that employ new technologies, or perhaps target different type of opioids or opioid mixed with stimulant or non-stimulant, non-opioid compounds such as xylazine, for instance. This is how you make a vaccine against opioids, as well as any kind of small molecule drug. There is a drug-based aptin here, stems from the structure of hydrocodone, oxycodone, through a linker is conjugated to an immunogenic protein, so that the immune system will recognize the old conjugate and produce antibodies against the drug target. Upon this basic design, the formulation can be improved upon by using new technologies or state-of-the-art components, such as new adjuvants, immunomodulators, formulation. And these vaccines can be given either as a monovalent, so targeting one specific compounds, or as multivalent by combining multiple vaccines to target multiple compounds at once. But the basic idea is always stimulating the immune system to actually make effective, selective, and long-lasting antibody responses against the target drug. Aptin design really drives the antibody affinity and the selectivity of the antibody response. And so, for example, within the class of fentanyl, we have generated a library. These are just some examples of that of aptins that will actually target either fentanyl or potentially some of the other fentanyl analogs as shown here. Efficacy, these vaccines, we test them extensively in mice and rats, and then when they work or we have a lead, we advance them to large animal models or humans. This is one of our typical screens to illustrate how these things work. These are animals who are vaccinated with a series of fentanyl vaccines, and then given fentanyl, and vaccines show reduction in fentanyl-induced antinociception or respiratory depression or bradycardia. If you look at the center panel, for instance, controls are down 50% bleeding, which for rats, pretty much, they're barely moving, they're turning bluish, while instead the other rats that receive the vaccine do not show that particular dip in oxygen saturation. We have done this for multiple vaccine candidates and tested in different paradigms where fentanyl is given either as a bolus or on cumulative doses or in combination with other analogs, and we have done that in mice, rats, and pigs. As far as fentanyl self-administration, so more of a chronic model related to reinforcement and reward properties, these vaccines are able to reduce drug intake. We have done in the past model where we either vaccinate first and then have animals acquiring self-administration, or we have done the opposite, where first animals are trained to self-administer the drug of interest, such as fentanyl in this case, and then we start the vaccination regimen. And in their case, the vaccine is able to reduce drug intake, and animals do not attempt to increase the drug intake to overcome the vaccine effects, when instead, like in this case, control animals do when challenged with a dose response. Also, ongoing data suggests that the vaccine can also prevent reacquisition of fentanyl self-administration. But obviously, some of these studies take like over like a year, and so we keep accumulating new data. Safety mechanism: once the drug is bound by the antibody, the drug no longer is active, and so cannot bind or activate the myopia receptor. For instance, on the left, we are showing how antibody drug complexes do not activate the human myopia receptor on a human cell line, or in the right panel, we are showing how fentanyl is buried deep into the binding pocket of the antibody by X-ray crystallography. And because it's so buried in there, cannot access pretty much receptors or the environment. We also shown, like we've done quite a bit of immunology studies looking if IgG complexes would actually trigger any antibody-mediated effector function, like would be in the case of a virus, for instance. We don't see any evidence of that. We see as the Fc neonatal receptors are required for the antibody half-life, but Fc gamma receptors or phagocytosis or NK cells are not involved in vaccine efficacy. As far as selectivity, we design and screen these vaccines for not binding off-target opioids or other off-target critical meds. And here is just an example showing that in vaccinated animals, anesthetics, both volatile and injectable, are still working, as well as naloxone is still effective in reversing heroin. Naloxone is still effective in reversing oxycodone, and also methadone. There is no interference with methadone in vaccinated animals. So these vaccines are proven to be selective, and we are hoping they will do the same in actual humans. As far as formulation, many formulation can be used to improve vaccine efficacy and hopefully reduce individual variability or increase overall mean group titers. Lately, we have select a toll-like receptor 7 and 8 because mainly like the TLR8 receptor is expressed in humans. And so we foresee that this particular adjuvant is suitable for translation. And we are showing is the efficacy of this new formulation in mice, rats, and pigs. Here we are showing how by adding these TLR7 and 8 agonists, we are actually increasing fentanyl-induced antibody titers, increase the effect on reducing respiratory depression. And now these effects are mediated by reducing the concentration or the amount of unbound drug that reaches the brain. This specifically I'm showing to you because is a formulation that we are currently selecting for IND-enabling studies, and we are currently manufacturing and planning the GLP tox for supporting an IND filing next year. As it's not moving, like it's like, okay, there you go. As I mentioned earlier, these vaccines can be assembled together. We have demonstrated in various like published research that essentially vaccines can be combined to target multiple compounds. In this instance, we have combined a fentanyl and a carfentanil vaccine that is protective against like mixtures of fentanyl and carfentanil. And now one of my students have reached, I think, an hexavalent vaccine where it's targeting multiple opioids plus methamphetamines, and they provide protection against bolus injection of multiple compounds at once. In this space, in order to support our program, we have also done some work on discovery of both preclinical and clinical biomarkers. Specifically, we are interested in either biomarkers that prior to vaccination can predict who's going to be a good responder, or after vaccination to understand which pathways are activated by this vaccine and vaccine components so that we can design vaccines with a specific selective activation of the immune system. And Dr. Comer will speak more to that in the next talk. Switching to monoclonal antibodies as a parallel program, we've been developing monoclonal antibodies to either prevent or reverse drug overdose toxicity. Monoclonal antibodies can be administered right away and can be immediately active compared to vaccines that will take a while to build up antibodies over time. Same as for vaccines, we've been developing a pipeline of monoclonal antibodies and antibody-derived products, going from early discovery to going towards manufacturing and IND-enabling studies. One of the lead humanized monoclonal is advancing to fentanyl and fentanyl and is advancing toward manufacturing, and is supported by an INIDA grant that me and Dr. Comer are co-PIs. And then we have other monoclonal antibodies against other opioid targets in the pipeline, as well as next generation antibody formulation that will hopefully enable delivery in the field like that can be potentially more cost effective. We develop a platform to isolate antibodies. We start from either mice or humans, or possibly lately from other species. We isolate opioid-specific B-cell lymphocytes, and from there we have a pipeline where we use different parallel workflow, whether it's hybridoma or sorting paired with PCR sequencing. But bottom line, we are able to express the antibody binding regions into antibody frameworks, and then we can actually engineer them for improved efficacy, stability, and so forth. The engineering process is sort of like hits both ends of the antibodies. We are looking at the Fab portion for humanization, as well as rational target mutagenesis supported by crystallography, as well as like improving the Fc portion engineering to potentially optimize the half-life of these antibodies. As an example here, these are rats that are infused with fentanyl to behavioral or pharmacological endpoints, such as oxygen saturation, and then these effects are reversed by the monoclonal antibody or by naloxone as a control. And what we are seeing is that like the monoclonal antibody dose dependently somewhat in between naloxone IV or sub-Q. We have also confirmed some of this data in larger animal models. These are pigs that are infused fentanyl up to apnea, and then after 2 minutes of apnea, we reverse that with either monoclonal or naloxone, and we are seeing like comparable effects supported by the pharmacokinetic of the monoclonal antibodies, which are almost immediately increasing the plasma concentration of fentanyl after antibody administration. Similarly, in non-human primates, we see data that are comparable to the pigs and the rats, where the monoclonal antibody can reverse respiratory depression induced by fentanyl, and is similar to naloxone, its kinetics, and obviously is a dose-dependent effect. And then, as I was mentioning, finally, especially now, when we started doing this type of work, we didn't really have access to structures. Instead now, because we have done crystallography studies of quite a bit of leads, then we can compare structure to actual sequence, and then engineer the actual antibodies to come up with either new designs that have new properties, or to improve the scalability and stability of existing leads. And we are deploying that to generate new antibody modalities that may have different profiles, for example, be given IM or intranasally and so forth. And then this is done like collaboratively, like there is my team back in Minnesota, also my team now in Seattle, Dr. Comer over here on Zoom at Columbia, and then like we have I guess like a team all over the country which specialize in different aspects of product development, and all the research is funded by NIDA and also by some private philanthropists or donors. And so thank you very much for your time.
Okay.
And,
Thank
yes.
you, Marco. That was great. You've done a huge amount of work, obviously. I think that we'll hold questions until the end. We've tried to keep the presentations relatively short so that it can be more of a discussion type of interaction.
Sorry, mine was too long, probably.
No, it was
My fault.
perfect. It was just perfect. Yeah, it was great. All right, so let me share my screen. Oops, hold on. And I'll show you the data, the clinical data. All right, here we go. Okay. Okay, so just show you the data we've collected in people. We have no conflicts of interest related to the contents of this presentation. I know Marco kind of went over it briefly, but I just wanted to put things in context in terms of the magnitude of the problem of opioid use disorder. So the World Drug Report that the United Nations Office of Drug Control has published very recently is estimating that about close to 300 million people have used drugs in 2021. The majority of the drug reports are for cannabis, but the next most common one is for opioids. And they also estimate that over 13 million people inject drugs, and that there are close to 40 million people who have a substance use disorder, but only about 1 in 5 are in treatment for their drug use. So even though the opioids only account for a fraction of the drugs that are used, they are, disproportionately causing harm. So opioids account for about 70% of deaths due to drug use disorders, and they account for about close to 40% of treatment. And, obviously this is a very costly problem in terms of healthy life years lost. So won't go into any detail here. Under this particular grant, we are funded to examine 2 of the vaccines, so the oxycodone and the heroin vaccine. And this is our multivalent vaccine concept. So normally vaccines will target a particular structure, right? So there have been nicotine and cocaine vaccines that have been in development previously, and some are still under development. For those substances, it's, relatively simple because nicotine's nicotine, cocaine's cocaine. There's just, one structure, and the vaccine will generate antibodies that will recognize those substances. Opioids are a little bit more complicated because they can vary pretty dramatically in chemical structure. And so we knew from the beginning of this program that we would have to develop a multivalent vaccine that would target the different chemical structures. So, this is the oxycodone vaccine. Because oxycodone, hydrocodone, and oxymorphone are chemically similar, then we're expecting that the vaccine will cross-react with, all 3 of these opioids. Heroin and morphine are different from the oxycodone group because they have different chemical structures. And so this is the other one that we're looking at. And then, as Marco mentioned in his presentation, we've more recently started developing this fentanyl vaccine in response to the fentanyl crisis. But this means that we can develop other, vaccines that can be added as the illicit drug opioid supply changes. So more recently, there have been nitazines that they're called that have started to infiltrate the illicit drug market. So the concept here is if you can think about it, is similar to the flu vaccine, right? So every year there's a different group of viruses that are expected to cause influenza. And so the flu vaccine varies from year to year. So that's kind of the way we're thinking of, this approach as well. As Marco mentioned, we can either, administer co-administered individual vaccines. So we have one for oxycodone, we have one for morphine, and we have one for heroin, and we can mix and match. So the clinician can give, a combination of a heroin and a fentanyl vaccine, for example, or they can give all three, or they can just give one. The other strategy is to have all of these haptens on a single carrier protein, and it would be a single injection of all of them. So we're still kind of working out the details of which one makes more sense, and maybe that can be one of our discussion items. So Marco showed you the data from the fentanyl vaccine in his animals. These are data that he collected in rodents for the oxycodone vaccine. And what I'm showing you here is that brain oxycodone levels decrease as a function of increasing oxycodone vaccine dose. And then correspondingly, there is the Hello? Oh. Correspondingly, there's a dose-related increase in serum concentrations. So, as Marco said, the oxycodone antibody complex is not behaviorally active, not pharmacologically active. So the blood levels increase because the substance is not getting into the brain. And then just behaviorally, there's a corresponding, because they're not getting into the brain, there's a dose-related reduction in the analgesic effects of these, this oxycodone. Importantly, the oxycodone vaccine also reduces oxycodone self-administration. So these are animals that were self-administering oxycodone and received the placebo vaccine. And then when the group that received the active vaccine showed the suppression of oxycodone self-administration, which is what we're hoping to see in our participants. So the animal study showed that the opioid vaccines are well tolerated and produce antibodies to the target opioid. Brain levels are reduced, and the pharmacodynamic effects are correspondingly reduced. But what we learned from the nicotine and cocaine vaccines is that there's quite a bit of inter-individual variability in the immune response to these vaccines, which ultimately led to treatment failure in large phase 3 studies, because, even though the people who were vaccinated, and I think, Richard and Meg were involved in one of the cocaine vaccines that were under development, it was effective in reducing the effects of cocaine in the people who showed a good antibody response. But when taken as a whole, that didn't happen. There was no significant difference from placebo. So, that's why, as Marco mentioned, a really important part of our work is to look at biomarkers that might help us identify before vaccination who will be a good responder. So the aims of our study are pretty straightforward. This is a phase 1A, 1B study. So the aim 1 is safety. Aim 2 is to measure the immune response. And aim 3 is to demonstrate preliminary efficacy. And I'll show you the data for each of these aims right now. But before I do, I just wanted to show you just a schematic of our study design. We give 3 doses of the vaccine at week 0, 3, 6, and then another booster dose at week 18. There's 2-week periods of inpatient stays, before the first vaccine dose, after the third vaccine dose, and then after the last booster dose of the vaccine. And during this period, participants received placebo, oxycodone at various doses, and then heroin as a positive control. We've modified this design multiple times because it was really complicated. Our IND was accepted in April of 2020 when everything was shut down. So our original design was for a longer inpatient stay. And so that just didn't become, it was just not feasible. Nobody was willing to stay in the hospital during that time. So we've, modified things. So these are the demographics of the subjects that we completed in our pilot study. So this was a first-in-human study. And the FDA asked us to complete a pilot study first. So we had a low-dose cohort and a high-dose cohort. And so they called this a 3+3 design. So 3 of the participants received an active vaccine and 3 received placebo. And then, we evaluated the data from the low-dose cohort. Our data safety monitoring board reviewed those data and then recommended that we move to the high-dose cohort. So this was also 3+3. So 3 active, 3 placebo subjects. So in terms of adverse events, we've had 4 serious adverse events in total, but none of them were related to the vaccine. They were most often related to, the lifestyle of drug users. So one participant in the low dose experienced multiple non-fatal overdoses that he reported during the extended follow-up period. Another participant in the low dose had an abscess secondary to IV drug use that required IV antibiotics. The 2 that were in the high dose cohort, one was a planned cholecystectomy that he didn't tell us about until after he got his first dose. And then the last case was of rhabdomyolysis following an intense workout. The only treatment emergent adverse event was one person in the low dose that reported, tenderness and soreness at the injection site. The second aim is immunogenicity. So as you recall, it's a 3+3 design. So 3 active and 3 placebo in each of the cohorts. So 6 participants total received active vaccine. And what we're showing you here, we haven't broken the blind yet, is that 5 of the 12 subjects demonstrated increases in oxycodone-specific IgG titers. And the average level was around close to 4,000 in what we're calling the responders. And then in the non-responders, the average antibody titers was 155. So here are the preliminary efficacy data. So this is from one subject who showed high titer levels. And what I'm showing you here is change from baseline in pupil diameter across time. So the closed circles are showing you, pupil diameters after receiving placebo oxycodone. And as you can expect, there was virtually no change in pupil diameter across the session. But when this participant received 50 milligrams of oxycodone, this is the pre-vaccination assessment, there was this, expected decrease in pupil diameter that, peaked at around an hour and a half after administration and then kind of started to slowly return to baseline. So that's a typical response. A week after the first vaccine dose, this is week 1, there's really no change in pupil diameter after this administration of the same dose of oxycodone. So, this just demonstrates that it takes a while for the antibodies to emerge. But after the third vaccine dose, this same dose of oxycodone that previously produced this robust decrease in pupil diameter produced no effect on meiosis, which is really impressive because this is a pretty hefty dose of oxycodone. But obviously, we need to collect more data to confirm these results. What I'm showing here are subjective ratings for 3 of the participants that showed, an immune response. So these are visual analog scale ratings of liking. On this scale, it's bipolar, so 50 means neutral. And this is dislike, and then this is like. So what you can see is that relative to, the week 0, which is baseline, after vaccination, there's all of the subjects showed a reduction in drug liking. These are small reductions for 2 of the subjects, but what we have reported in previous studies is that a 10 millimeter reduction in subjective ratings usually maps onto a clinical response. So this is ratings of, good drug effect. Again, this robust decrease over time in these participants. And this one is more robust in this subject, even though there's a relatively small change here. So this is encouraging. It was all in the right direction. Obviously, again, this is a very small sample size, so we need to keep testing. And then I'll just switch gears really quickly to talk about our biomarker work. I'm not going to show you the data because I want to give time for Dana to give her presentation. But these are some of the biomarkers that we're looking at before vaccination that we're hoping will correlate with immune response after vaccination. And as Marco mentioned, what we're hoping to do is sorry, can't see the slide. What we're expecting is that, the biomarker will be correlated with, the efficacy of the vaccine against the drug. And this is the group that we would hope to enroll in a clinical trial. So these are data that Marco collected in his lab in mice, showing that pre-vaccination IgM B cells were correlated with post-vaccination antibody titers against oxycodone, right? And then correspondingly, the pre-vaccine, these same 4 animals were the ones that showed the lowest brain levels of oxycodone. So that was all, really nice, positive data. And he's published this several years ago. In our study, what we found was that post-vaccination oxycodone-specific B cells are correlated with, the oxycodone-specific IgG titers. Same with this oxycodone-specific plasma cell. So these data are generally consistent with the data that were collected in mice. And we're currently looking at whether the pre-vaccination oxycodone-specific B cells also correlate with this post-vaccination antibody responses and efficacy. We did this study a while ago looking at biomarker, a variety of biomarkers in people with OUD compared to people who were opioid naive, and none of these participants were vaccinated. So if you're interested, I can show you the data maybe during the discussion, but I just wanted to summarize what we found. Okay. So the mice studies, the studies in mice showed that pre-vaccination B cell activity is correlated with post-vaccination opioid antibody titers. The pre-vaccination B cell activity was associated with cytokine expression in our study. We found that the cytokine expression is associated with opioid use patterns, both in terms of number of bags per day that were used, as well as number of years used. So we're wondering if, all of these kinds of potential biomarkers might be related to post-vaccination opioid antibody titers. And as I mentioned, the clinical implications are that, these groups, if we can identify them before vaccination, may result in a positive clinical trial. But, we have a lot of work to do. And, hopefully we'll show you the results of the main trial in the next year or so. So I'd just like to thank, everyone in the opioid lab who has helped with collecting these data. It's a really fantastic group. I love working with everybody in the lab. So that is my presentation. Okay. So Dana, do you want to pull up you have a presentation, right?
I do, yeah, I have a PowerPoint. Do you want me to go next, or do you want Ned to go before me? Either way.
I was expecting that you would go next, and then Ned would kind of to end our presentations.
Perfect.
Okay.
Okay, let me share my screen. Okay, does that look appropriate? Okay, great. So my name is Dana Sacco. I'm an emergency medicine attending physician here at Columbia. The title of my talk is Clinical Perspectives on Fentanyl Monoclonal Antibodies for Overdose. When I was first asked to talk about this, my thought was, I don't know anything about monoclonal antibodies for overdose. I have no idea what I'm going to say. And my second thought was, nobody who works in the emergency department really knows much about this at all. So in preparation for this talk, which was actually a lot of fun, I made appointments and meetings to speak with a number of friends and colleagues who work in this space, people who are trained toxicologists, addiction medicine folks, people who do SUD research, largely emergency medicine docs, and also an addiction psychiatrist and an internist. And over the course of a number of meetings, I started to sort of for myself create a framework for how to think about how this could fit in the emergency department context. And so my goal for the next 10 to 15 minutes is to sort of try to lay that out for you, sort of what I've been thinking and kind of my framework for thinking about it. Okay. This is going to be a really clinical talk because that's what we do is ER docs. And so what I want to first do is kind of paint a picture for you of what it looks like to take care of a patient with an opioid overdose in the emergency department. Sometimes we get notified by EMS before they're coming in. Sometimes they hit the door and the triage nurse tells you that there's one who's coming to your area. Usually you come out to triage, you see the patient. Hopefully you overlap with EMS to get a bit of a history, what happened, whether they found the patient down with drug paraphernalia, whether somebody saw a patient collapsed on the subway platform and a bystander called EMS, whether naloxone was given pre-hospital and by whom and how much. And as you all know, there are multiple things that opioids do to people in overdose. The most dangerous is the hypoventilation. And so our goals with reversing opioid overdoses in the emergency department is to reverse that respiratory depression that opioids cause. When you give somebody a big slug of naloxone, it is very effective at reversing that respiratory depression. The downside is that it puts people in precipitated withdrawal. They get sweaty. The cardiac lead sticking to their chest on the monitor won't stick anymore. The adhesive holding their IV down comes up. The patient wakes up, is upset. They often pull out their IV. So in residency, one of the things that I learned by our toxicologists is this sort of trick that's kind of a more elegant way to reverse people. The idea is that you can take the 0.4 milligrams that comes in 1 ml in a vial of naloxone, diluted in a total of 10 cc's, so that you're working with something that's a little more dilute. You can push aliquots of 2 or 3 cc's at a time, with the idea of being able to titrate it to reverse the respiratory depression without fully reversing them and putting them in precipitated withdrawal. Sometimes, so naloxone lasts about 60 to 90 minutes. As you know, some of the opioids are longer acting than that. When the naloxone wears off, we might need to redose naloxone. In some cases, we need to start people on a drip. Those patients get admitted to the ICU. Anybody who needed to be intubated to protect their airway also will get admitted to the ICU. I would say a big cohort of patients can just get naloxone once or twice. They clear, we watch them for enough time, and we discharge them. And then in between, there's those patients who haven't fully woken up enough, but they don't need a drip. Maybe there's something else going on and they get admitted. So the disposition ranges from anywhere from an easy discharge to an ICU admission for these kind of patients. This is my super lo-fi timeline to just kind of show for re-narcotization, the recurrence of that respiratory depression that we're concerned about. People take opioids, depresses their respiratory rate enough that we need to give naloxone. Then about an hour later, that happens again. We get more naloxone in that time in between. I think that's going to potentially be important for this talk, because when patients are awake enough to have a conversation with us, hopefully not put in so much so much withdrawal that they are sort of unhappy and trying to leave. But in that kind of moment where you can have a conversation with somebody about what their basically what their situation is, where they're at with their opioid use disorder, if this is something that could be the right treatment for them. How many people require repeat doses of naloxone? I wasn't able to pull that data from our ER before this talk, but I have a couple tables, this slide and the next, to kind of get at that number, how often we need to repeat the dosing of naloxone for these folks. This is from a paper 2022 from Emory. The specific question they were looking at is whether people who've ingested fentanyl need more doses of naloxone than people who don't. They didn't find that was the case. But why I'm showing it to you is because in this box that I've highlighted, we can see that about 23% of the people that they included in this trial needed a repeat dose of naloxone less than an hour after arrival, and 8% an hour after arrival, and then 4% needed an infusion. I would say that that 4% is probably a pretty good reflection of how often we start people on naloxone infusions. It's not that common, but of course, when they do, they have to go to the ICU. So that's a big deal. This paper, probably a lot of you are familiar with. This is a paper out of Mount Sinai from earlier this year, looking at xylazine present with opioids and people who did not have xylazine, and their outcomes for this paper were looking at cardiac arrest and coma. But this table I think is interesting because they found that a little over 40% in their xylazine positive and xylazine negative cohorts required repeat doses of naloxone. There's reasons to believe this is a sicker cohort than the average sort of all comers with opioid overdose. They mentioned that in their limitations. So the truth might be somewhere between a quarter and a third of patients need repeat dosing of naloxone after their initial dose. Okay, so next I want to just kind of talk through 3 different clinical scenarios we might see for people coming into the emergency department after having gotten naloxone given to them pre-hospital, whether that was by a bystander who had intranasal naloxone on them, or EMS showed up and gave it IV or IM, or also intranasal. This isn't meant to be exhaustive, but I think it does sort of broadly capture a lot of the different types of scenarios we see. Patient 1, we have a 56-year-old woman who was maintained on Suboxone treatment successfully for a couple of years, who relapsed. Family found her down. They gave her the intranasal naloxone that they had at home, called EMS. EMS brought her to the hospital. Patient 2 is a 34-year-old male who uses cocaine intermittently, went to a party, used cocaine, didn't know there was fentanyl in it, collapsed. Friends called EMS. EMS gave naloxone in the field and brought him in. And then patient 3 is a 42-year-old male with opioid use disorder who is a daily user of opioids, heroin, and fentanyl, not interested in treatment. One thing that came up a fair amount when I was talking to the people that I was consulting with and kind of getting my ideas together for this talk was this idea of whether somebody is in the pre-contemplative stage of change. And we'll talk a little bit about that later. I'm sure a lot of you with psychiatry backgrounds and addiction backgrounds are much more familiar with that than me. But patient 3 will be our pre-contemplative kind of patients. And the case I'm going to make is that patient 1 and patient 2 are better candidates for this treatment than patient 3. Okay, so the fentanyl and monoclonal antibodies, a little bit about the medical perspective, and then the patient care sort of ethical perspective of using these in the emergency department. First, and this is a lot of what you guys were already talking about, no need for repeat dosing of naloxone for patients who get these. That's great. That means that we don't need to watch them as closely on a monitor. Nurses don't need to be constantly kind of checking in to make sure they're breathing well enough, and neither do the doctors and residents. Provides medium-term protection against overdose. There's data to show that after a non-fatal overdose event, the 30 days after that are pretty high risk for repeat overdose. So these would be the pros. Cons would be, would it precipitate withdrawal? Withdrawal that would potentially be hard to treat without using another medication that the patient might not have wanted, like buprenorphine. For the period that required the infusion, if it's similar to like an infusion clinic, you'd need nurses to watch that patient for, typically in infusion clinics, it's like 30 minutes and then another 30 minutes to make sure that they don't have any reactions. So potentially upfront need for increased nursing resources. The patient will need a good IV if that's the way it was going to be given. And then cost, which I obviously don't know anything about, but would potentially be a con if it's very, very expensive. But I think from the emergency department perspective, also really important are the patient care and ethical concerns. Operating from a point of patient-centered care, we believe patients would need to consent to receive this kind of treatment. The patients who are pre-contemplative probably wouldn't be interested, and that not getting consent would significantly restrict an individual's liberty. This was something that one of the people I talked to, with phrasing he used that we sort of discussed a lot. Patient-centered care defined as treating a person, receiving healthcare with dignity and respect, and involving them in all decisions about their health. Okay, so I'm sure a lot of you are familiar with this. The whole point of the stages of change from pre-contemplation, contemplation, preparation, action, maintenance is not to say that patients move through this linearly, which is often why it's kind of depicted as this spiral or sort of cycle, but is to say that conceptually, the being able to meet someone where they're at, someone who has opioid use disorder where they're at, is probably going to be the most effective way to get them on a path to treatment. So the goal would be to identify people who are interested in pursuing treatment and not interested in abstinence. Okay, so this is a reflection back on the earlier clinical scenarios. Ideal characteristics of the patient would be the patient who is not an opioid user, that is the patient who's using methamphetamine, cocaine, something that was tainted with fentanyl. In that case, we wouldn't expect fentanyl the MABs to cause withdrawal. The patient would be opioid dependent, and it would help protect that patient against fentanyl. For patients who are opioid users, the ideal patient would be somebody who's interested in treatment or already on MOUD, basically not in that pre-contemplative space. Ideal characteristics of the drug. And I know that some of you guys spoke to this already. It wouldn't preclude the ability to receive analgesia when it's medically indicated, wouldn't precipitate withdrawal. If there was a way to give it quickly and not require that kind of prolonged infusion time, that would be ideal, not prohibitively expensive. And then as far as how long it should last, I can't really speak to that. It might be true in trials that you would find out if you told a patient that these MABs lasted 5 days or a week versus a month, that might make a difference in how people felt about it. But I'm just not sure about that at this point. So basically, coming back to this idea, I think that there is a period of time when a patient is sitting in front of you who has been reversed, who is talking to you, that you can try to elicit where they're at. Are they somebody who really is not interested in being exposed to opioids because they're not an opioid user? Or are they somebody who is in treatment, wants to get back into treatment, maybe hasn't been in treatment, but is ready for that? I think being able to identify those people, and if they are having a re-narcotization event, offering that at that time would be kind of the ideal scenario. There's one more thing I want to say, and that's this. What we've talked about so far is specifically using MABs to reverse an opioid overdose. But I think using this, offering this treatment to patients, not necessarily to reverse an acute overdose, but right after an overdose, sort of as a treatment kind of going forward, I would say is also a really interesting space to do it. When people show up in the ER, having received naloxone, waking up, they realize they just had this near-death experience. I think there's reason to believe that in that space, people are more amenable to harm reduction strategies than they might otherwise be. And being able to refer a patient from the emergency department to this kind of treatment in the same way that we do bridge clinics, like the model for bridge clinics, which is the idea of taking somebody in the emergency department and within the next day or two, getting them seen by sort of an intermediary clinic to get them started on their MOUD or continued on their MOUD being buprenorphine, Suboxone, or methadone before they're plugged into their long-term care. Some sort of model like that, I think, could be interesting, with the idea that it's a patient-centered approach, would be easier to obtain consent, would allow you to select who could be more appropriate and potentially increase the number of patients who could receive the treatment. This slide's important to me because I really appreciate all the people who were willing to talk with me about this. And then also thank you to Sandy for asking me to speak.
Thank you, Dana. That was really interesting. And I forgot to mention actually that Dana is one of our chosen pilot awardees. So she'll be studying xylazine and the clinical characteristics of people who come into the ED who have xylazine in their system. So our last speaker then will be Ned. Do you have any slides, Ned, that you wanted to show? Ned, you're on mute. I'm not sure if you were
On mute. Can you see my slides?
Yeah.
Okay.
It's not in presentation mode though.
Yeah, let me go into presentation mode. Come on. There we go. How's that?
Yep.
Terrific. Okay, so I thought it would be interesting just for sort of by analogy to think about naltrexone and buprenorphine as particularly naltrexone, which is a blocker of opioid effects and its use therapeutically. The vaccines and the antibodies are intended ultimately to block opioid effects. So what can we learn from what the clinical response is to the medications we have in terms of where the vaccines would fit into our therapeutic armamentarium? So let's talk mostly about naltrexone. So naltrexone extended release, it's a high affinity opioid receptor blocker. It's like long-acting naloxone. And the thing about it produces a very dense blockade. Patients on an adequate blood level of naltrexone don't feel anything when they inject opioids. And it works for fentanyl too, as far as we can tell. And they say, I felt nothing. Patient said, I shot up, I felt nothing. I realized I was wasting my money. And they don't use. And it also blocks the craving, interestingly. There's very little craving on naltrexone, and similarly with buprenorphine. It's broad spectrum, of course, going to block all opioids because it's blocking the receptors. And the extended release formulations get around poor adherence with daily dosing. They last about a month. So duration of effect is one of the issues. Dana was talking about that, and that's a key issue. But these extended release formulations last about a month. This is just quickly a little data. This is the XBOT study, which was a large randomized trial in the Clinical Trials Network of people with opioid use disorder presenting for hospital treatment. Actually, they were hospitalized on addiction treatment units, and consenting individuals were randomly assigned to 6 months of treatment with either extended release naltrexone or sublingual buprenorphine. So the blue line here, and this is a relapse curve of time to relapse. So the vertical axis is proportion of patients who have not relapsed, and it's the horizontal axis is time in the trial, 24 weeks. And the red curve is the naltrexone, and the blue curve is the buprenorphine. And what you see is the buprenorphine does a little better. Look at panel A on the left-hand side. The buprenorphine does a little better. That difference is carried mainly by the fact that 27% of the naltrexone patients never managed to initiate naltrexone on the inpatient unit because they have to get through the induction hurdle. If you go to the right-hand slide, which is just patients who take their first dose of medicine, there's really not much difference between the two groups. And what it shows is about 50% of these patients, whether it's naltrexone or buprenorphine, don't relapse, which means they are predominantly abstinent throughout this 6-month period. And almost all the relapse has to do with stopping the medication. Patients don't relapse while they're have an adequate blood level of the medicine. They relapse when they miss a dose and become unblocked, if you will, and that's when they relapse. This just shows the craving goes down very rapidly within 2 to 4 weeks for both treatment groups. Craving actually goes down a little bit more with naltrexone, which is the red curve. The next slide is the Russian pivotal trial, and this is just a slide that shows every dot horizontally is 24 weeks in the trial. And if the dot is red, the patient is present and abstinent. If the dot is blue, the patient is present and using. And if there's no dot, it means they dropped out. And just focus on the right-hand plot, which is the Vivitrol group. And it's interesting. There are a lot of placebo responders, as you can see in this sample, but patients on naltrexone don't use much. It's mostly red dots. There's very little use. And the other thing is when they use, they tend not to drop out. Whereas on placebo, you look over here where patients are dropping out, a lot of times there's a blue dot right before they disappear. So they're not blocked. So the blockade keeps people from using. They'll test the blockade once in a while, but then they won't use. There's always been this concern clinically that patients will try to override the blockade. They'll be blocked and they'll just keep taking opiates until they feel something. Clinically, that almost never happens. What happens is patients say, I felt nothing, I was wasting my money. So I stopped trying. Buprenorphine is very similar. This is a similar heat map from the pivotal trial of Sublocade, which is the extended release buprenorphine injection. The left two panels here are showing 24 weeks on the buprenorphine extended release injection. It's a monthly injection. The left-hand plot got a 300 milligram injection throughout the 6 months. The right-hand plot got 300 for 2 months, followed by 100 the rest of the months. That didn't really make much difference. What you see here is the green dots are where a patient, and remember, every row here is a single patient. The green dots are patients who are present and abstinent. And you see in buprenorphine, 40% anyway, are predominantly green. They're predominantly abstinent. So it's you get a good blockade and everything. And then they're interesting on buprenorphine. There's quite a few patients, sort of between 60 and 40 here, who are mostly red, but they're still around. So is that perhaps because buprenorphine is not producing as strong a blockade, or more likely variation in blood levels? I like to show this slide because it shows that there's basically no placebo effect in outpatients with opioid use disorder. The placebo group, you see, it's all red except for a few greens, and then they drop out. So to the point being that these pharmacological blockers are very powerful at blocking opioid effects as long as the patient stays on the medicine. And the problems are, of course, two problems. The patient stops the medicine, or there's quite a bit of inter-individual variation in the blood levels people get. And that patients with low blood levels are more vulnerable to relapse. The variability in blood levels is a lot more than you might think from just reading the package inserts. On Vivitrol, there are patients that are below the minimal effective concentration by day 14 after the injection. It's supposed to be a 28-day thing. And clinically, we see patients starting to have craving and using at day 21. There are also these implants that are coming out. There's a Russian implant that lasts for 2 months, supposedly. There's an Australian implant, which we're studying here now, which produces adequate blood levels for anywhere between 3 and 9 months, but quite a bit of individual variation. Some patients get three months and that's it, and their blood levels crater after that. And some people have good blood levels out to 9 months or more. So there's all this variability in the duration of adequate blood levels. So what are the implications? I tried to think a little bit, what about the implications of this for vaccine design and effectiveness? So there's blockade specificity, which Sandy and Marco talked about in terms, and the medicines now, naltrexone and buprenorphine, have broad spectrum. They block all opiates, basically. The antibodies are specific to a family of opioids. But it's good to hear that there are preparations with multiple antibody targets that could be prepared. Then there's a question in my mind of blockade density. Will the effect of the antibody be enough to fully block opioids, similar to naltrexone, let's say? Or will it attenuate opioid effects but not block them? And if they attenuate opioid effects, will that help the patients not use? Will they crave less? Or will they try to override the blockade if it's only a partial blockade? And then there's the issue of blockade duration, which I'd love to hear more about. We heard already from Marco that there is, and Sandy, there's a lot of inter-individual variation in blockade. And one of the questions I had is whether, and I'm sure you are thinking about how to convert non-responders into responders. Is there some way to stimulate the system to be more, is there some way to foster those B cells and so forth that seem to be predictive of antibody response? But again, how long will it last? Will it last a month? Will it last 6 months? Would the responders get antibodies for a year? How long does it last? That's clinically very relevant. And then what would the indication be? Is this a primary treatment for opioid use disorder, similar to naltrexone or buprenorphine? Or is it an adjunctive treatment to those medications? And I'm wondering if it would be more the latter. Patient stops their buprenorphine or naltrexone and the blood level drops, but they still have antibody on board. Does that help protect them? Does that help give them a cushion so that they can decide to get back into treatment, or the clinical team can reach out to them and get them back into treatment? Protection against overdose. I mean, if you've got a good fentanyl antibody blood level, that would be probably really useful to give to patients that are on buprenorphine or naltrexone, because it would protect over and above the protective effect of the medication, especially if the patient misses their dose. So, Marco, you talked about cross-reactivity with methadone and buprenorphine. Well, you didn't say anything about buprenorphine, so that was really my question. Do these cross-react with buprenorphine? Because if they did, that could be a problem. Obviously, that could interfere with the therapeutic effects. That was a question I had.
Yeah, no, they do not. They were selected for not cross-reactivity, so they don't bind methadone or buprenorphine, naloxone, naltrexone. So
terrific.
Yeah.
And then finally, my last question: are you thinking about how to convert non-responders into responders, ways to precondition the immune system to respond to these things? And so that's the clinical questions that come to my mind when I start to think about how would these vaccines be used clinically. So it's very exciting, and I hope we can have some discussion now.
Yeah, thanks, Ned. And I guess just to jump in and on your second to the last bullet point, we actually added a second group, because we were having trouble recruiting people who were willing to come inpatient. So in our current design, we have a group of people who are in treatment, so they can either be on methadone or buprenorphine. We don't give them, oxycodone or heroin challenges, of course, because we don't want to disrupt their their therapeutic situation, but we're testing the vaccine, and we've had no evidence at all that the vaccine is doing anything to their treatment effectiveness. So I think that's one of the unique advantages of this approach, because if the data, like I showed you on the pupil data, hold up, and these guys are just really not experiencing the effects of opioids, then it maybe would be as robust as naltrexone in that regard, or even buprenorphine or methadone. And maybe they would be effective enough to use as standalone medications. But if that's not the case, then I think it would be entirely feasible to, give both MOUD and vaccination.
And in the high titer people, how long do you think the titers last? You have a sense?
We've been measuring that. That's why we have such a long follow-up period in this study. It's, we're measuring them out to 42 weeks. We actually extended it out to 96 weeks because we're getting some hints that maybe the vaccine, the antibody response was even longer lasting. But the cost is just kind of prohibitive, and our grant can't support that. So I mean, I guess I'll let Marco address that, because he's looking at the at those data.
Yeah, I mean, that's very important. And the question is also not so much like how long the titers will last, but also how long the titers will last above a certain threshold that is protective. Because if you say, well, you can detect them up to 2 years, but once they drop below a certain concentration, they're no longer protective. And again, as you know, that could be a function of also what type of patient you're using, you're dealing with it. Because if somebody is relapsing and may not be using like the same doses that they may be using, like, before, when they were actually using, if the dose is sufficiently low, perhaps those titers are still protective. But if somebody's using their I guess their standard dosage, it's not clear, like, when the antibodies will stop being protective. But again, like, probably there is a case, like from your presentation, like, Ned, about how to titrate, kind of like also naltrexone depot, like closer to the end of like the depot, beyond that 28 days, that's when you start being vulnerable, because the concentration of naltrexone drops pretty quickly.
Well, of course, you want to give you want the patient to take their shot every 28 days. I would think more about giving the vaccine at the same time as, or around the same time as, the Vivitrol.
Yeah.
In the hopes that if the person's an antibody responder and those antibodies last for 2 months or 3 months, that it buys you time. We have such a big problem clinically with patients dropping out of treatment. And that's when they're really in danger. And so if this were something that could put the brakes on and protect somebody, let's say from fentanyl overdose during this period when they drop out of treatment, it buys time to get the person back into treatment. So that's just something to think about.
Yeah, that is also a formulation. Sorry to interrupt you.
Can you stop sharing the slides? Because maybe we should open it up for.
Oh, I thought I had. I'm sorry. I don't see how to do that. Wait. Oh, wait. Here we go. Pause share. Stop share. Okay.
There we go. Thank you. So anybody else can join in on this discussion, but sorry, I interrupted. Go ahead, Marco.
Oh, no, I was saying that in the past, we published a study where, like, we deliver, I took Vivitrol from the pharmacy. I opened it up, I mixed it up with the oxycodone vaccine and injected IM in rats. And that was protective against like very high doses of oxycodone. And just like you described, Nat, after the naltrexone like drop off, then the vaccine is still protective. And so potentially you could combine them. That's pretty extreme, so you could potentially go to the deep end and say, well, you have multivalent vaccine plus Vivitrol, and somebody could argue that you no longer have any options for, pain treatment, or, I guess.
Although, so much of the overdose risk is fentanyl and carfentanil, and if you had a vaccine for those, maybe the patient still takes heroin or they get some oxycodone, but they still could be protected. I guess, there's the question of what to do if the person is all blocked up and can't respond to opiates. Dana, what about ketamine for people who don't respond for pain control?
It's a good thought. I think it's an interesting thought. Yeah, I mean, we use ketamine in the emergency department for various things, and I would say that as a practice, we are not primarily using it that much for analgesia, but that might shift as people become more and more comfortable with using ketamine.
Oh, David, do you have a question?
Yeah, and these were wonderful talks. I'm gonna try to lower my hand. The what just came up in Q&A actually segues nicely to something that I wanted to both mention and ask about, which was, I guess it was a few weeks ago that a press release came out from, I guess it was University of Montana, on upcoming trials for a fentanyl vaccine. And if you looked on what used to be called Twitter, there was the reactions from harm reductionists and patient advocates were mostly ones of horror and saying, this is a terrible idea, and mostly their main fear was that if a multivalent vaccine would essentially leave no escape hatch for pain relief and emergency anesthesia. Mm-hmm. But so the negativity of that response led me and some of my post-bac trainees who are on this meeting as well to want to do a survey study that would look at sort of attitudes and barriers to uptake and among active users who I don't think have been surveyed yet, and ask let them know what this is what's in the works. These are the options for it. What do you think about this? And I don't want to reinvent the wheel by doing that. So if that work has already been done and I don't know about it, it would be good to know about. But also I want to throw it open to the panelists and everybody else here to say that we would love to frame it and assess it and ask questions that would be useful for these projects. So any comments or thoughts on any of that?
As far as I know, I mean, Dr. Epstein, that's a very great point. So I know of two reports. One, there's a colleague at the University of Wisconsin in Madison, through the School of Pharmacy. They actually have conducted a survey and published amongst pharmacy residents to ask the attitude of pharmacists towards live vaccines. And then there was a report out of there's a group that is working on vaccines for opioids at BCH. At Harvard, Boston Children, and they have published something. It's not really like an academic report. They didn't really survey many people, but it's more like a discussion of who would be open. So me and Dr. Comer talk about doing such a questionnaire of this type, asking patients if would be interested. Or even here, in psychiatry at UW, we start discussing that. And then finally, sorry, not to, I had something to ask also on this kind of application to Dr. Sacco as well. One thing that people, I don't know if I could be practical, but because the antibody, so in extreme cases where you have multivalent vaccines, for instance, differently than naltrexone, because the multivalent vaccine produces antibodies that are not going to go into the brain or the spinal cord, you could potentially still do pain management via spinal tap. So you could deliver opioids intrathecally, and that would still work. Well, I'm not so sure that would still work with the vitro.
Also, related question, how much fentanyl, for example, would it take to saturate the fentanyl antibodies produced in a responder? Because presumably, once you saturated them, then the fentanyl would start to work.
I've been trying to be approved by IACOG. Yeah, that's a sort of a lost battle to do LD50s. But in rats, I went up to 30 milligram per kilogram given to rats, and the vaccine is still preventing overdose. And obviously in a human, 30 milligram per kilogram, that would be a ton. And I don't know if that will translate, but that's pretty.
The thing that's really nice about the fentanyl vaccine is that, it's basically a stoichiometry question, right? And because fentanyl is so potent, the expectation is that it would be very favorable, the vaccine, the antibody levels.
Yeah, right.
So, but, just to get back to your question, David, if you have interest in conducting that study, we would totally be interested in collaborating with you about that. Because I think it's a really important question. And I think it's ironic, actually, that people are so concerned about, the horror of, oh, what would happen if I got into a car accident and I needed an opioid. And it's ironic in the sense that, that was exactly the same concern that people had about the extended release naltrexone, because you're completely blocking all the opioid receptors for this long duration of time. And it really, you know, with naltrexone, all you do is really, you know, you could just give more of the opioid in the clinical setting and it would override the blockade. But naltrexone, you know, covers all opioids, right? And the vaccine is, because it's so selective, there are lots of opioids that would be effective, like methadone, tramadol, buprenorphine. You can use them as analgesics in these patients. So in that sense, it's a little bit better. So I think, you know, I remember I was sort of involved in this whole effort when the bystander use of naloxone first became sort of a thing, and a lot of people were really hesitant about that as well. And I think it's just going to be a matter of you know, educating people about what the vaccine does and doesn't do, and what the pros and cons are, just like with any medication. But Emily, do you have the question?
Yes, I do. I'm actually one of David's postbacks that he referenced that's super interested in this project. Very cool stuff. But I had a question that's kind of along the lines of this vaccine hesitancy and what we talked about earlier. So I was wondering, since it seems like it's still pretty open or you're still testing it, what, in your opinion, is the ideal durability of the vaccine? So I can see the need for frequent booster shots as a positive. So keeping that free will of if someone decides to use again, or as a negative, because I think what was discussed earlier was that a huge problem is medication adherence, and that's what this vaccine would really help with.
I think that's an Ed question.
Yeah, I think the ideal durability would be, you know, as long as possible. And if there was guidelines about frequency of booster shots, that'd be good. And you know, from a harm reduction point of view, I can even imagine, you know, if someone wants to take the fentanyl vaccine because they want to be protected, they still, I mean, harm reduction is a little bit of a difficult philosophy for somebody who's primarily a clinician to get their head around. But if someone wants to use heroin or opioid painkiller pills, oxycodone, but wants to be protected against fentanyl, or wants to take cocaine and whatever other drugs where fentanyl is getting into the, I mean, one of those cases that Dana, that you presented, I think, was somebody that was taking cocaine, right, and was adulterated with fentanyl. So if it was a patient that wanted to keep taking drugs, you know, but wanted to be protected and from fentanyl and its analogs, that would be a use case. But short answer, as long as possible, and with some clear indication as to when to give boosters. And of course, it's interesting that you can measure the titers, because if there is this variability, inter-individual variability in titer response, then, you know, you'll want to know if somebody's a responder or not. You know, if they're not a responder, there's not much point probably in giving the vaccine, and they also should be made aware that they're not protected. And again, my question is there a way to condition? You know, is there a way to stimulate those B cells and plasma cells so that they become more susceptible to the vaccine?
I don't know. I mean, I don't know that's the short answer to that question. But I think one approach that we've been taking with our colleagues at the University of Montana is that not so much at the individual level, but sort of at a group level, we've been working. I mean, they're experts in adjuvants for vaccines that generally will boost the immune response. And so that's what Marco was talking about with the TLR 7 and 8 adjuvant. So what we're hoping by adding that kind of adjuvant is that little box that I had at the end of my graph will be bigger. You know, so there'll be more people at that end with a strong adjuvant.
That makes a lot of sense. Thank you for your response.
Yeah, and just Emily, another response to your question is I've rarely, if ever, had a patient be upset because they've been given a treatment that blocked their opioid effects. The motivation varies, but usually when it helps them, they appreciate it. So
Mhm.
I wouldn't anticipate a lot of trouble from the patients themselves coming back and complaining, said, darn, you took away my high. They're more
Mhm.
likely to say, I'm glad you protected me, even though I really wanted to get high at the time. That's sort of more what we're inclined to hear.
Yeah, I read an article, and now who wrote it is escaping me, but they did do a poll of fentanyl vaccine acceptance and how long people ultimately would want it to last. And while the name is escaping me, the statistic is still in my brain. And I think 76% of people preferred lifelong durability. So that aligns with all of your responses.
Yeah. When we first ran our sustained release naltrexone study, we thought that we were going to have a really hard time recruiting people who were willing to be blocked for an entire month. But that was our fastest enrolling study. People were really interested in it, so we were surprised.
Mhm.
Sorry, Meg, you had a question?
Well, just a comment, because like David, I saw the response on Twitter, former Twitter, and it was very, very intense. But again, working with the cocaine vaccine, people also had the impression that it was going to be this completely total blockade. But Sandy, your data showed it reduced, and that's a positive effect. Like, it didn't knock it out entirely like naltrexone did. So I think that's a little bit part of it. They think of it like, I don't know, hepatitis vaccine or some other vaccine.
But does that
really
depend if you're a tighter responder? In other words, do the high,
right, but even your best case scenario, your best responder, it's still not it's not a dramatic effect so far. It's a nice attenuation, but it wasn't gigantic. But I wanted to just also, because I think so I really like the vaccine approach, I completely understand and I appreciate. What I found really interesting was, our cocaine vaccine required 3 shots, but after that very first one, when there's virtually no antibody, everyone told us, oh my gosh, I can't feel cocaine anymore. Like, they had this tremendous placebo response to this very salient vaccination. But my question really is about the monoclonal antibody approach, because, like Dana mentioned, I guess I'm still wobbly on what that's buying us in the ER versus naltrexone.
Well, go ahead, Dana.
Versus naltrexone in the ER versus naloxone.
Or naloxone. Yeah. I mean, what is that buying us, the monoclonal versus an opioid antagonist, for somebody who's overdosing or
would you do both?
Well, I think there are 2 things. One is that, as Dana mentioned in her presentation, there potentially Marco, I think, is working with Charles France to answer this question, but you wouldn't expect to see precipitated withdrawal with the MAB, which is the big problem with naloxone. The other thing is that, like Marco showed some of his data where you can give both. Exactly right, Ned. That you can give both and potentially give less naloxone so they don't get as sick. The MAB is really, really effective. It's very, fast acting, and it provides a longer duration of protection.
Okay, but so it doesn't precipitate because it's not a really fast kicking off the receptor. Is that why it's not precipitating? Because you would think it would.
Well, I mean, we are trying to demonstrate that by PET imaging, but essentially, like, the monoclonal antibody post-exposure reverses pharmacological effects, but we think it's like drawing essentially like unbound fentanyl from the brain across back into the periphery, but it's probably not going to displace fentanyl from the opioid receptors. And so even if it's acting as fast as naloxone, the mechanism is more pharmacokinetic than pharmacodynamic. So far, we haven't seen any evidence. So if you compare animals, you get them dependent, you give naloxone, you look at behavioral scores for precipitated withdrawal, the MAB doesn't do that. Or we have looked at intracranial self-stimulation. So I think that it's about the kinetics. I mean, probably, and I don't know, I've never done it, if you inject ICV, so directly in the brain, like the monoclonal, if the monoclonal has an affinity higher than the opioid receptor, perhaps you would see withdrawal, but that's also not what is happening in the actual whole system.
So those are the two advantages, I would guess, is that no precipitated withdrawal and longer duration. But Dana, do you think there's anything else that?
I would, yeah, I mean, it seems like naloxone works so well that it seems like the main thing that you would be doing, just as far as like reversing the acute overdose event, making sure somebody's not dying in front of you. I think that the main advantage for the right population would be the ongoing protection. I think you'd have to identify that right population, but then, the data that shows that, like, if you show up in the ED with a non-fatal overdose, in the period of time after your risk of a fatal overdose increases, you'd be protecting people against that,
The monoclonals they last long?
Yeah.
The methamphetamine mAbs that are under development now, they're currently in clinical testing for methamphetamine overdose. They last for like up to 2 months.
Oh, wow. Oh, I didn't realize that. I thought
Yeah,
they got shot up fast.
No, they depend upon the type of antibodies. So, for example, like our humanized monoclonal, full monoclonal in monkeys, like protects up to 4 weeks. So every week we keep like challenging the animal with like fentanyl, and that is like full blast like those, and then the antibodies could probably stick around longer. And now we have engineered, just like people do for HIV and other disease, we engineered the FC portion of the antibody to have like 4 times like the half-life, and so they could stick around for 3 to 4 months.
That's really interesting. But they must go through withdrawal at some point, right?
Yeah. Yeah, presumably.
Dana, I was interested in your comment that you need informed consent from the patient to give the monoclonal. You thought you would need to get consent from them.
I do, and pretty much everybody that I spoke with sort of unanimously felt that this being such a, it's sort of kind of forcing somebody into a treatment of sorts, right? Which is a really ethically kind of murky decision to make for somebody.
Yeah, it would be like giving someone in the ED, Vivitrol. That would not be appropriate, right?
But I have in that context, like 2 examples come to mind. Well, one up here in Everett in Washington, they're testing in the ER the anti-methamphetamine mAb. So people come in, high methamphetamine, they get them to consent, and then they give them monoclonal. So that's one. And then I was thinking that if you have somebody that is obviously overdosing, cannot consent unless you reverse them with naloxone, and then they can consent. And the other one, I posed the same question to known psychiatrists, known addiction, and they say, well, what if like somebody's coming like with a life-threatening like a staph infection, and you're prescribing them certain type of treatments that can be very expensive. Those are just administered to the patient, and so why this should be different in terms of consent to like a life-threatening infection that requires immediate, infusion of antibiotics.
Well, we're over time, so this has been really fun to have these discussions, but I think we should probably let people go.
Yeah, thanks everybody for joining.
Yeah, thanks for joining.
Thanks to all the panelists. They're really terrific. Very exciting.
Thank you.
Thanks, Ned. Bye.
Bye. Enjoy your evening. Thank you so much. Bye-bye.
Thank you.
Bye-bye.